Good morning, everyone. My name's Janet Rossand, and I'm the President and Scientific Director of the Gairdner Foundation, and I'm pleased to welcome you all to today's event, Vaccination, Moving Forward with Confidence. This event is part of our series of Gairdner Global Perspective panels, where we convene scientific and public health leaders from around the world to bring their insights on current and pressing issues. Before we begin, I'd like to briefly introduce the Gairdner Foundation, our mission and our programs. The foundation was founded in 1957 in Toronto, Canada, by local philanthropist James Gairdner, with the main goal of recognizing and rewarding international excellence in fundamental research that impacts human health. Since that time, 395 scientists from over 35 countries have received the Canada Gairdner Award for their incredible work, 95 of whom have gone on to win the Nobel Prize. The Gairdner Foundation is also committed to fostering growth in the Canadian scientific community and inspiring the next generation of researchers and innovators through our outreach programs and our public events like this one today. I encourage all of you watching today to follow us on Twitter, Instagram, and Facebook at Gairdner Awards and share your thoughts on today's events. Please also, as you listen to the presentations, if you have questions, please submit those questions for the speakers in the chat box, and we'll attempt to get to as many as possible during the Q&A session. I'd also like to thank the sponsor of today's events, GSK Canada, for their generous support. You can visit their sponsor booth by clicking the Expo tab on the left side of your screen after today's panel. Now I'm going to invite our moderator, Ivan Semeniuk, science reporter at the Globe and Mail here in Toronto, to introduce our first speaker. I'm sure many of you listening today are familiar with Ivan's great work as a science reporter for the Globe and Mail. And during his career, he's worked as a science journalist, editor, broadcaster. Prior to the Globe and Mail, he worked for the journal Nature, New Scientist, and the Discovery Channel. So thank you very much, Ivan, for joining us today.
Thank you very much, Janet, and good morning or good afternoon to everyone who is on the line watching our presentation today. On behalf of the Globe and Mail, it's my great pleasure to be with you to moderate this panel. I would say an extremely timely expert panel, and hopefully one that will answer many of your questions and open new areas of exploration around our pressing topic of vaccines and the vaccine rollout around the world. I'll be introducing each of our guests and panelists in turn, and then after their presentations, we'll return to help moderate the question and answer portion of the panel. So without further ado, I will introduce the first speaker, and that is Dr. Heidi Larson. She's a professor and anthropologist, a specialist in risk and decision science, and director of the Vaccine Confidence Project, which is based at the Department of Infectious Disease and Epidemiology at, the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. She's also a clinical professor at the University of Washington in Seattle and a guest professor at the University of Antwerp in Belgium and the National University of Singapore. Dr. Larson previously headed the Global Immunization Communication effort at UNICEF and chaired Gavi's Advocacy Task Force and served on the WHO-SAGE Working Group on Vaccine Hesitancy. Her research focuses on the analysis of social and political factors that can affect uptake of health interventions, with a particular interest on risk and rumor management. And in that vein, she's also the author of Stuck: How Vaccine Rumors Start and Why They Don't Go Away. Thank you very much for joining us, Dr. Larson.
It's nice to be here. I'm going to talk about the global picture of COVID vaccines and issues around hesitancy and how we can try to address them. Some of it has been just the power of, as we call it, social proof, as more and more people are getting vaccinated, but we still have quite a few bumpy roads ahead. I founded and direct the Vaccine Confidence Project 11 years now, so this is not a brand new issue. And we look at the global dynamics around the changing landscape. It's almost like watching the weather report. Things are constantly changing, storms coming in, issues moving. And we're trying to understand also what's locally driving some of these issues, and have recognized that it's not just about issues around the vaccine itself, but it's about the trust in healthcare providers, in the system, in government, and also in policies and own culture and belief systems. The landscape is highly varied. I don't think I've seen two countries that have been even close in terms of their different issues and the way they play out. This was a nice map that the FT made of our 2019 data, which was 149 countries around the world. And this just captures the range of the issues. And as you can see, Japan is at the low end and India is at the top, but there's a lot of variation in between. But I just put this one up here to call out the point that the way we see hesitancy is very much an artifact of people's histories with vaccines and in trust. The Japan low level of hesitancy was very much knocked down from higher levels because of an HPV vaccine scare. 8 years ago, a number of girls reacted to vaccines, which were assessed by the investigation as being more psychosomatic, but still the anxieties persisted, and it's really undermined the 8 years of not being recommended has really undermined public trust, and it's playing out around COVID. We mapped the changing weather, as I mentioned, around the importance of vaccines, the effectiveness, and the safety. Dark red is low confidence, dark blue is high confidence. Good news is that the importance of vaccines, the confidence importance, has gotten better over those years. I would like to see these maps again in the post-COVID. Effectiveness has a more fractured landscape, but safety really is where we see the most volatility and changing sentiment and anxieties. And we're constantly looking not just on the state of things, but more importantly, where things are going up and down, where's the changes. And here we picked up really quite a significant change in a drop in confidence in North Central and more in West Africa, more the Francophone countries. And we're seeing a lot of sentiment diaspora going with language diaspora. And France is kind of the epicenter in terms of the lowest confidence country in the world in general. It was in the FT map, it was close to Japan. Japan had a drop below there, but we really see how that language diaspora carries sentiments. We've seen this with different diaspora communities also. The biggest change in confidence were between 2015 and 2019 were Indonesia and the Philippines. And again, like in the case of Japan, they were individual vaccine events that knocked down the overall vaccine confidence. Philippines in particular was quite high in confidence. The issue in Indonesia was related in 2018 to a group of Islamic leaders who decided that the new MR vaccine that was measles rubella vaccine being introduced in a campaign was actually haram. It wasn't religiously compatible, and it really undermined public confidence, and to this day has affected COVID pandemic. But to the credit of Indonesia and the National Immunization Program, having been through a pretty difficult time with the measles rubella campaign, when it came to the COVID vaccine, and Indonesia was one of the early countries to roll out COVID vaccine. They had started with the Chinese vaccine from Sinovac. they not only got the scientific assessment and regulatory approval, they made sure that they had the endorsement, the public endorsement from the Islamic Council. So they tried to mitigate and learn from that experience. And I think this is a really important point in terms of it's not always just about the science if we want to go from vaccines to vaccination. In the Philippines, as I mentioned, it was one of the top 10 countries worldwide and dropped to less than the 70th, under the 70th. And this was related to, I'm sure you're all familiar with the Dengvaxia events, where a risk was reported a year after 850,000 school children were vaccinated with Dengvaxia. But the risk was a real risk, unlike this situation in Indonesia. And this was a small risk that if you had no previous exposure to dengue, you could get more serious dengue. And that created a political uproar, unlike what happened in Brazil, where they had the same rollout, not quite as large, but after the risk was reported, they retrained up, they carried on, they made sure that in giving the vaccine, they took the appropriate screening and information with patients. So politics matter also. In the case of the Dengvaxia vaccine in the Philippines, again, it's really made the work harder to build confidence around the new COVID vaccine. So these histories matter. I just published last week an editorial in Science on the volatility of vaccine confidence. There's, as you've seen, many surveys are out there in different countries, in different settings. But we have to, one thing I always do when I see a new survey is look at the date, because you can see surveys that are really out of time. I know just after the issues last week with different information coming up and continuing about the AstraZeneca vaccine, there was a lot of coverage of a YouGov survey talking about drop in confidence in a number of European countries. And the way it came out in the media, it looked like that was a result of some of the EMA announcement that it was safe to use. But actually, this survey had been before that. So I think it's always really important to look at the date of any survey if it's evident. It's understandable about the volatility of sentiment more than ever in the context of COVID. I do a lot of research on rumors and what makes them stick, what makes them sleep and revive. And the setting we're in now, the hyper uncertainty, brand new virus, brand new vaccines, multiple vaccines, made in new ways, and the threat of the pandemic, the changing variants, it's a very uncertain time. So I think the volatility of sentiment is understandable, and we really need to have empathy with people's questions and concerns. This is a cartoon. Rino saw this in another panel I was in. But where do we, there's a lot of people waiting for, I want other people to take it before I do, or I want to be 100% sure. Well, I think that some of these issues are the relative risk, the looking at the threat of the illness, and the timing. This is a lot about timing too, if we're going to rein in the pandemic. India was one of the highest in the FT map in terms of confidence. And overall, in a number of our surveys from different angles, India does have pretty high general public confidence in vaccines. But around the COVID vaccine, it's been a different kind of struggle. It's going well in some places, but usually in the very first leg, the willing come forward. But I think in the coming months, it's really where we're going to start seeing some of these harder pockets becoming evident. And then we have the power of belief, which is not just about safety, not just about importance, and not just about efficacy of the vaccine or the threat of the pandemic. We have political leaders who themselves are either playing down the virus or promoting alternative cures, promoting religion, promoting organic cures. And when the leader of a country is either downplaying the threat of the disease, part of the challenge we face, for instance, in some settings, is denial that COVID is even that bad. So if people don't believe that the issue's bad, and there's any point to think about a vaccine, it doesn't matter about the safety and efficacy. This is not just in Africa that we see this here in London. We see it in across Europe, in the U.S., in a number of countries. People saying, "Where is this pandemic?" And also the other point of this particular article, and I make this point a lot, we're so focused sometimes on misinformation online, we miss the billboards and the pamphlets and the other ways that people are communicating. People still communicate in gatherings and outside of social media. And this is also in London, where COVID is a hoax. So it's not just leaders in other parts of the world, it's around us in many countries. So that's another aspect of it. It's not the dominant one, but we have to keep it in play, the mix of beliefs, of actual genuine concerns, and recognize this spectrum of hesitancy that is going from very reasonable questions to extreme beliefs and denialism. In Africa, we just finished with Africa CDC, and you may hear more from my colleague from Africa CDC. We did a 15-country perception study around COVID vaccines, and across the 15 countries, I don't believe there is corona. It's made too fast, too new. I want to see what the effect on other people. I don't trust it. These 5 top things, issues we found there were totally consistent with what we've seen in countries around the world, no matter what economic or cultural setting. These are strong themes. So while there are global themes, they play out quite differently depending on the setting. We do, as I mentioned, a lot of surveys around the world regularly since last May, June. Confidence has been up and down. And what was really striking to me in this analysis we did was this was just in December with 32 countries. Dark red is definitely will not take a vaccine. Dark blue definitely will. Of all the socioeconomic and other demographic variables, sex, age, education, employment, income, general health, the strongest correlate of willingness to take a COVID vaccine was not any of the typical socioeconomic social determinants of health, as we say. It was the perception of how well the government was handling the epidemic, the trust in the government in how they were managing it. If there was high trust, there was higher willingness to take the vaccine. We also look subnationally because at a national level, you can miss some of the variation. This is a more in-depth mapping of the UK in terms of willingness to take a vaccine. We see London and Manchester, and urban settings are more complex, more mobile, a lot of different mix of groups and access. And what looks, if you only saw the headlines, mostly looks like the numbers are quite high here. But when you break it down by ethnicity and group, the picture is quite different. The other concerning trend we're seeing, not everywhere, but certainly in pockets everywhere, is hesitancy among healthcare providers, healthcare workers in in long-term care centers to nurses and doctors. And this was a recent JAMA paper that came out, and really it was the unknown risks and insufficient data that many of them reported, and side effects, but it was, so these are very genuine questions and concerns, but from the public perception, when your healthcare, the one you trust, the one you turn to, your healthcare provider or worker or vaccinator, first question they're going to get is, have you taken it? And that's a concern we need to pay attention to. Globally, the World Bank has just published a recent assessment on preparedness and readiness for countries around the world for a global rollout of the COVID different vaccines in 128 countries. And it was pretty striking and shocking in a sense that the two lowest levels of preparedness were around social engagement, community engagement strategies, communication, and the second arrow is meant to be down along processes for vaccine deployment training. So healthcare professionals and the training for the frontline workers was only, there was only readiness in 30% of the countries. And that's, I think, the importance of building confidence among healthcare workers. I would put it the absolute top of the list, because they're really our frontline advocates or people who can actually assure others, and if they're not confident themselves, that's a concern. This is the book that was mentioned, my book Stuck, and really to really recognize that we have to have some empathy with a number of the questions of the public, and not, while science is absolutely foundational to all of our efforts, that we have to put them in the context of emotions, of historic experiences, and understand that people have reasons for their concerns. This is our website, the Vaccine Confidence Index, and there's lots more there. Thanks very much.
Wonderful. Thank you very much, Dr. Larson. I'm now going to turn to our second panelist, and just a reminder that we'll be taking questions after all the panelists have presented. Our second panelist is Dr. Rino Rappuoli. He is Chief Scientist and Head of External Research and Development at GSK Vaccines, based in Siena, Italy. He's also Honorary Professor of Vaccinology at Imperial College London and Extraordinary Professor of Molecular Biology at the University of Siena. Previously, Dr. Rappuoli was Head of Vaccine Research and Development at Novartis, Chief Science Officer at Chiron Corporation, and Head of Research and Development at Sclavo. Among other honors, and he has many, I'll just point out, he's the winner of the Canada Gairdner International Award for his scientific work, which includes contributions in areas such as genetic detoxification, cellular microbiology, and reverse vaccinology, to name a few. He has also developed licensed vaccines, including for acellular pertussis and the first conjugate vaccine against meningococcus C. Dr. Rappuoli is also the founder of the GSK Vaccines Institute for Global Health, and in his scientific leadership, he's been dedicated to the sustainability of global health. Thank you for joining us, Dr. Rappuoli.
It's a pleasure to be here with you today. Today I'm going to talk about vaccines and monoclonals that have been developed at incredible speed in 2020. And we'll see how they can help us really to get out of this pandemic. Now, what I'm going to talk about is that I believe in 2021 we will start to control this pandemic, thanks to two things: vaccines and human monoclonal antibodies. And as I said, they've been developed in really an incredible speed for two reasons: technology and for really an unprecedented investment in development manufacturing, which has been done by the public sector. A year ago, when people were asking me how long it's going to take to make a vaccine, my answer was, well, usually to make vaccines take 10, 15 years. We are in a pandemic, we're going to be fast, but best possible thing is going to be 18 months, maybe 3 years. Instead, in 10 months, we got vaccines actually approved for emergency use. So the question is, how did we make it? So I'll talk a little bit first about the technology that allowed to do that, and then the investment that allowed to have such a speed. About technology, in this slide, I summarized the technologies that have been used to make vaccines. Initially, vaccines were made by empirical approaches. We will grow viruses, bacteria, parasites, we'll kill them and inject them, or attenuate and inject them. Then we started to have different waves of technology, recombinant DNA, glycoconjugation, genomics, reverse vaccinology, and so on. And every wave of technology allowed us to conquer new things. Today, we are in a moment where I believe we see an explosion of new technologies. And what I usually say is that today we can do things that 5 years ago were impossible. And probably in 5 years, we'll be able to do things that we cannot even dream about today. Now, specifically about COVID vaccines, there were 4 technologies were absolutely instrumental. One is the ability basically to do vaccines using genomics downloaded from the internet. 2 is the ability to design stable antigen by structure-based design. 3, about using synthetic genes and making RNA vaccines, synthetic biology. And 4, adjuvants, and which are used for protein-based vaccines. Thanks to these new technologies, I think with COVID-19 vaccines, we have made the transition, which I call the transition from analogic vaccines to digital vaccines. What do I mean by that? Well, I mean that up to now, basically, to make a vaccine, we needed to grow a virus, to grow a bacterium, to grow a parasite, and that was the basis to make a vaccine. And that's why I call analogic, because you needed the matter, you needed the virus, you needed the bacteria, you needed to be a microbiologist, you need fermenters to grow them. Today, we are in the era of the digital vaccines, where you can make vaccines without having the virus. In fact, all the COVID vaccines that we have were developed when the Chinese put on the website, on the internet, the sequence of the genome of the virus on January 10, 2020. And next day, the more than 300 groups worldwide were able to download the sequence, make synthetic genes, and use the synthetic genes to make vaccines. So basically, vaccines are made by using the digital information without having seen the virus. I mean, up to that moment, for instance, if we were in the old times, we had to send the virus from China, maybe to CDC, maybe to other places. Will take a few months and then other months to grow the virus. And this time was instantaneous. Send the sequence, make a synthetic gene, make a vaccine. So the vaccines have been made, basically all started from the synthetic gene. And a synthetic gene developed just from using information in the internet were used to do three types of vaccines. One, the RNA vaccines. These are fully synthetic. You make a synthetic gene, you basically transcribe in vitro, and you make a synthetic RNA, and that synthetic RNA is your product. And this was extremely fast. In 66 days from the downloading of the sequence, people were in clinical trials. The alternative use of the synthetic gene is basically to take the synthetic gene, put into a viral vector, chimp adenovirus, adeno26, many viral vectors, and then you grow the virus, and then you use the virus as a vaccine. This takes a little bit longer to construct the virus and grow the virus, but it's still very fast. In 3 months, we were in clinical trials. The third way of using the synthetic gene is to make a more classical vaccine. As you take synthetic gene, you put into a cell that's going to express the synthetic gene, and the cell can be a mammalian cell, can be a tobacco cell, it can be an insect cell, and then you use that cell to produce the protein, the spike protein of the virus, and then you purify the spike protein, you add an adjuvant, and then you formulate the vaccine, then you go to clinical trials. This takes longer because you have to make the cell, purify, add the adjuvant, formulate, but once you are in clinical trials, then it's fine. So these three types of vaccines were developed and they were in clinical trials in 2020 quite rapidly. And then we started to get clinical trials data very quickly. But the other thing we really accelerated the vaccine development, and in addition to the digital transition, has been the investment. The investment to the public sector, 15 billion were invested by the public sector, mostly by the United States, more than 10 billion, but also by other countries, European Union, and so on. Why that was important? Well, to understand that, we need to see how vaccines are usually developed. Usually you make discovery. Once the vaccine is discovered, you have a proof of principle in the laboratory. You move in the early development, you do phase 1, phase 2 clinical trials. Once these are successful, you go into the late development, which is the most expensive and the most labor consuming, because then you do phase 3 trials, you build the manufacturing plant, and really is a lot of work. Altogether, takes 1 billion, more or less, to develop a vaccine. And 10% for discovery, 20% for early development, 70% the rest. In companies, we never do early development unless the first one is successful. We never do the late development unless the second part is successful. And therefore, takes a long time. Now, companies cannot afford to do otherwise. But this time, the government came in and said, please don't do these things sequentially. It's going to take a long time. Do them in parallel. As soon as you have discovery done, you have a safety data, you move to phase 1. As soon as you have some data, you move to phase 2, and you do phase 3. It's going to be a big financial risk, but the government is going to take it. So we take the financial risk, and you please go in parallel. And so basically, instead of taking years, now we took 10 months to get the final thing. The beauty of this is that none of the steps which are essential to figure out the efficacy and the safety of the vaccines have been skipped. All of them were done. Instead of doing them sequentially, they were done in parallel. And this is really an incredible acceleration that was done thanks to the investment of the public sector. And now the vaccines have been developed. Now are viral vectors, as I said, RNA, and more traditional spike proteins plus adjuvant. In order to understand how they perform, basically we need to look at this blue arrow down here. This blue arrow basically is the span of the neutralizing antibodies that are found in people that are convalescent from the disease, that in theory, they have antibody levels that allow them to protect them. Now, as you can see, all vaccines are induced antibodies which are above this line, which is the minimal antibody level found in convalescent. So all of them were supposed to be effective, although the titer of antibodies was lower in viral vector, higher in RNA, and still higher in proteins plus adjuvant. The efficacy basically confirmed that all these are effective, but the efficacy of the viral vector is slightly lower, while the efficacy of the RNA and the protein-based is actually incredible, 95%. I mean, very difficult to get conventional vaccines this kind of efficacy. We should be very proud. The other thing is that to say that this is efficacy against infection, but all these vaccines are actually 90% protective against severe disease and mortality. So they're extremely good, I would say, as vaccines, and incredibly fast to develop them. So these are the vaccines that we have. They're already being deployed. We should be very proud of this miracle that we managed to do to develop vaccines in 10 months. When we're very happy about these vaccines on controlling things, basically started to see variant kind. The first one was a period early in 2020. Then we had some variants coming up in Denmark. Then we got Brazil. Then we got the UK. Then we get the variants in South Africa and in Japan, and now there are variants I mentioned in New York, in California, everywhere. So are these variants going to jeopardize the efficacy of the vaccines we develop? The answer is somehow yes. At least the South African variant, we know that basically all the vaccines induce lower antibody titers against the South African variant. We also know that the Johnson & Johnson vaccine and the Novavax vaccine that have been tested in South Africa, they have lower efficacy, the 50-60% instead of 90%. And the AstraZeneca had a very low efficacy. So potentially some of these variants may be less sensitive to vaccines. On the other hand, we already have some of the companies doing second generation vaccines that will cover also the variants. And even more encouraging, we have data showing that when people are convalescent from the disease or given one dose of vaccine, they get incredibly high titers of antibodies, and they do cover all the variants. So I think we have the technical tools and the scientific knowledge to take care of the variants. Will take a little bit longer, but we'll do that. So that's about the vaccines. The couple of slides about the other tool that we've been developing very fast, which is basically passive immunization, human monoclonal antibodies. Passive immunization is not new, was done 1890 for the first time, first Nobel Prize. Von Behring that basically produced the serum against diphtheria toxin, and it was a life-saving tool. Today, instead of we develop human monoclonal antibodies, and we already have data that these are press releases because the papers are not out yet, but basically the human monoclonal antibodies from Eli Lilly basically provide 87% efficacy against hospitalization and death, and the ones of Vir and GSK, 85% efficacy. So we know that human monoclonal antibodies are also a tool that allow us to give these antibodies to people that are positive, that have been infected, and we can prevent mortality and hospitalization. There are 3 or 4 monoclonal antibodies already out. We have also been working on human monoclonal antibodies. We basically selected some of the most potent monoclonal antibodies ever developed. And basically, we found that they bind the spike protein of the virus at the very tip of the receptor binding domain. And our antibody, we found that is basically able to not only to control the wild type virus, but also controls the mutants from South Africa and from Brazil and from the UK. So it's a pretty broad human monoclonal antibody. In our studies, we are now in clinical trials. And with that, I want to conclude, basically, I think what I've shown you is that thanks to technology, investment, and resilience, basically, in 1 year, science has been able to catch up with the pandemic. We have tools that can control this pandemic. The question is how we're gonna deploy them, and obviously we started vaccinating maybe 100 million people right by now, but we have to vaccinate 8 billion. So that's a long way to go. But the science is there and is going to provide the tools. So my conclusion is that passive immunization with vaccines and human monoclonal antibodies is probably going to give us our liberty. Why am I talking about the liberty and why I'm taking the Statue of Liberty here? Because I think this pandemic has taken away a lot of our freedom. The freedom to go out, to walk, to work, to travel, to meet friends, to visit relatives, to go to theater, sport events, everything. I mean, we really need to get out of this. And fortunately, science is going to help us to do it. With that, I'd like to thank you for your attention.
Thank you very much, Dr. Rappuoli. It's a wonderful segue to our next panelist. After talking about vaccine hesitancy and vaccine production, we're now turning to the challenge of vaccine delivery to all those billions of people that Dr. Rappuoli mentioned. And we'll be doing that with our next panelist. Shanelle Hall is the founder of the Yellow House. It's an organization created to advise, convene, and advance thinking in health and sustainability-related topics, among other global challenges. A key focus of the Yellow House is on access to vaccines, medicines, and health-related technologies. Prior to founding the Yellow House, Shanelle was Assistant Secretary General at UNICEF, where she spent 2 decades helping to achieve bold targets by bridging the capabilities of the private sector with the needs of people and national ecosystems. She's known for helping reform UNICEF's humanitarian action and redefining how UNICEF engages with markets, most notably through her development of vaccine security, a healthy markets approach to an affordable vaccine supply that helped make quality vaccines accessible to the world's most vulnerable children. Shanelle has roles in a range of committees and organizations, including Gavi, the Vaccine Alliance, the Global Fund to Fight AIDS, Tuberculosis, and Malaria. She's also a trained negotiator and industrial and systems engineer, and has worked in the corporate and energy sector. Sounds like all the ingredients needed to deliver vaccines to billions of people. Shanelle, thank you very much for joining us.
Thank you so much. It's really an honor to be here. I want to talk a bit about, like you've described, access and what has worked and what hasn't worked. We know COVID has transformed many parts of our society, and some temporarily and some more permanently or longstanding. And we've just heard how, in terms of vaccine access, most of the rules have been broken. And so we want to look at that and see what can we learn from our, so far, access to COVID vaccines, and potentially what can we apply to that to increase even more access to vaccines in the future. So maybe starting with what kind of is a contrived grouping of different eras of vaccination, really marked by an energy or a goal or a new strategy to help achieve greater access to vaccine, and sort of ending with some shortfalls, some challenges. And if we look at the 2 decades starting from 1980, smallpox had just been eradicated. There was great optimism about all that could be achieved for child health through the use of basic vaccines. There was a universal childhood immunization campaign started by UNICEF and WHO, and many new vaccines started to be developed in high-income countries. And over time, all of this energy resulted in fact, more children being vaccinated with the basic vaccines, also a next generation or second generation of vaccines being developed, maybe just to bundle the number of vaccines included in one injection to reduce the number of injections. But overall, over time, after 20 years or so, there started to be a gap between vaccines that were accessible to children in low resource settings and those that were accessible to children in high income settings. And around 2000 is when there was a new energy, new strategy. Gavi was launched, in fact, which is an alliance for vaccines and immunization, to target some of these issues, to really reduce the time it takes to get children in lower resource settings access to new vaccines. And they did that by having money on the table that represented real secure demand to industry, by rolling out policy on vaccination set by the World Health Organization, and helping countries invest in their systems, in their supply chain, in their training of health workers, in their demand generation. So really strengthening their in-country. And it's been a great success. There are other things that were happening during those 2 decades. So additional 10 vaccines or so were introduced in many high-income countries. The U.S. BARDA organization was launched in 2006, which really has, and we'll see in this, or I'll show you a bit of how that really is transforming maybe how we think about accessing pandemic vaccines. Anyway, just to say there's been a lot of progress in the last 2 decades, but nonetheless, there's still children that aren't reached. The reaching the last 20% has been really tough. And it's still taking about 20 years to get access to vaccines. And so what are we learning from COVID that could decrease some of these timelines and increase health and improve economies? I'll start by just saying a bit that I'll reference World Bank income. The vaccine market really does tend to segment access via these traditional GNI designations. You can see here how the groupings are now, which has really changed compared to maybe when Gavi started. There were many more countries that were low income, but with economic growth that has changed. And just maybe to highlight that Gavi, which really is a pooling mechanism to help with equitable access, targets that group of countries. If we take a look at what is the average time it takes to get a vaccine, well, overall, we can see that it takes 20 years for a vaccine to be fully scaled, regardless of country setting. And what's interesting is that low-income countries get access oftentimes around 10 years later, but they tend to scale it more quickly if there is sufficient production. So if we just take a look at a few of these, so HIB, which was received marketing authorization in 1989. It took 24 years for all high-income countries to have access to the vaccine. Upper middle-income countries, they started introducing the vaccine 7 years after it received marketing authorization, and it took them 13 years to roll it out. And low and lower middle-income countries, it took them 13 years to get access, and then only 12 years to roll it out to scale. And we can see a similar pattern where there's a longer delay for low and lower middle income countries to get access to a vaccine once it has been launched. But what's interesting is through the support from externals, but also just through really strong immunization programs, they are sometimes shorter in scaling it out. And maybe to highlight that in a few of these places where it did take longer, when we look back and look at, well, what are the basis? There's still production shortfalls. And for HPV, low and lower middle income countries are waiting 2, 4, 5 years in order to have access to the vaccine. So it's not so much their systems that are the block, but it really is there enough vaccine produced, and when do they get access? Which is why when we start looking at COVID, well, 3 vaccines at least were received emergency authorization at the end of last year in high-income countries and in China. And we're estimating that it's going to take about 9 months from high-income countries to scale, and 12 for all other countries, which is radically different. And we know that the pandemic creates a sense of urgency that we won't get during kind of peacetime, so non-pandemic time. But still, are there lessons that we can learn from how this was managed? And so what is different? Again, I think we heard from Rino that it takes on average 10 years in the past to develop a vaccine, 20 years to roll it out. So we've really been talking that on average, through all these efforts, it's 30 years to roll out a vaccine. And we will anticipatedly do it in 2 years for COVID. And these are some ideas of what we're seeing in terms of what is different. So first of all, goal setting. So I'll talk about that. We got lucky with new platform technology. Rino probably wouldn't say we got lucky because the nucleic acid platform had been under development for years, but we did get lucky in terms of timing, and that really compressed the lead times. Governments shouldered financial risks, and also was described not doing the steps in sequence, but doing them in parallel, really reduced timelines and just bold contracts. But what's been the same? Well, in fact, still lower middle and low income countries are having slower access, even though there's been some really neat mitigations put in place. So COVAX, which is also run by Gavi, and it is a tool to help with equitable access by sharing risk and pooling contracts and procurement. Africa CDC, for the first time, has gone to the market and also created a portfolio of vaccine contracts for the continent, which is precedent setting. And then in a new form, China and Russia made donations of their vaccines. And all of this has moved forward access that people in these countries received. And all that in the context of the key actions that were taken over time. So if we look back, what happened last year? So the first genome sequence was made available in the 10th of January. The 11th of March, the pandemic was declared. And by June, there were almost 200 vaccine candidates that were under development. So a massive effort. 11 already in June were in human trial, and 5 billion was on the table in contracts to draw down access. And you can see how rapidly that evolved, and eventually by the end of the year, there were 3 that received emergency use. I want to talk a bit about goal setting, because we see that as really something that is fundamentally influencing access and delivery. And this chart shows the month of the goal. So Israel's goal is by April of this year to immunize 67% of their population. And these are the goals that we picked up that were been publicly stated. And you can see that it varies. So the US has a goal of 80% by May. Brazil has a goal of reaching 25% of their population by June. And you can see, just the variations. And it's interesting when we think back about when some of these goals were set, the target was to reduce deaths, and others it was to really also to reduce transmission. And the use case of COVID vaccines really is something that evolved over time. So again, perhaps because there was concern that there wasn't going to be able to be large volumes of vaccine available immediately, the first goal setting for many countries was targeting high-risk groups. And that percentage of high-risk groups as a portion of a population varies from country to country because it depends on the age of the population and their comorbidity rates. But still, on average, WHO and COVAX used a 20% as a target. And over time, those many countries shifted to targeting all adults. And the use case will continue to change, including potentially adding a booster dose for variants, or maybe an annual vaccination. And then there's still a question on a pediatric dose. What we also saw happening is how fast countries were to contract. So again, by July, there were at least 5 billion doses on contract. And you can see that governments created a portfolio in order to mitigate their risk. So they contracted with many different manufacturers for many different types of vaccines. And this has really put fuel and started to mitigate risks from the manufacturing side. So rapid contracts for large volumes. If we look at contracts that exist as of today, this shows those contracts and it compares them with the goals that we could find that countries had stated. So if you look, for example, again here in Israel, their goal of April, they had 12 million in their doses would be needed for them to achieve their goal, and they have 24 million doses on contract. This orange dot here shows it's okay, that's double the amount that they would need. And you can look at these variations that because many countries weren't sure which vaccines were going to materialize, the success rate is way exceeded, I think, everyone's expectations. And so we are looking like that there will be some excess capacity production, assuming that there aren't production scale-up problems. But there is a question about how you can see these big variations. In some countries, for example, in the case of India, their goal is to immunize by July 300 million people. They need 600 million doses. And according to what they've made publicly available, they only have just under 300 million doses available. And it impacts, we can see that how there's been export bans on COVID vaccines from India, and we start to be able to see potentially some of the reasons. But overall, we can see there was more or less larger contracts put in place than what countries needed. In some cases, there's still a gap, and the timing of the goals is also something to look at. If we zoom in on BARDA, and BARDA was the organization that's a part of the U.S. government's Ministry of Health. They placed some of the earliest orders, and already in March had contracts with Janssen. In April, they had contracts with Moderna and Merck, and then continued on. And this is something we just need to look at the impact of fast contracts. I think Rino has mentioned the importance of the nucleic acid and how that was so transformative. But a year ago, when these contracts were being placed, no one knew if that was going to materialize. So banking on that, or accepting that risk and having that be a part of the portfolio was super important. We can look at progress on deliveries, and this is where we start to see, well, there is in fact an unequal delivery rollout. You can see here the doses delivered in light blue compared to the doses in goal. And some are moving faster along than others. The percentage of the goal that has been reached. So Israel is one of the highest, followed by Chile and the UK, and then the US. And overall, that the lower rates is around 10%. And it begs us the question: if we set goals of all parts of the population, or the majority, or 67%, which is the estimated equivalent of herd immunity, rather than going for that whole goal to start, would it have been better if countries received at least deliveries to protect their high-risk groups before countries really started to get more upwards of 30, 40, 60%, while some countries are receiving 10%. As was mentioned by Rino, again, one of the transformative approaches was to tackle the decision making that happens in steps, and there's a pause between these steps, but have those happen in parallel. And there was really a convergence of the regulators, the clinical work, the decisions on production capacity, and even production. So working as a team, and that really changed how quickly these vaccines could be accessed. So from our perspective, we think there are a few things that we still see that 30 years is too long for people to be waiting for vaccines that could be life-saving. 20 years is too long to roll it out. So we think that it's critical for there to be more clear goal setting, so clearer, specific, include timing. We think that buyers should be including a buying of capacity and not only doses, and more shouldering the risk. So not waiting for the vaccine to be licensed, but potentially participating in some of the risk sharing with manufacturing in order to get better access. We've watched what's happened with regionalized approaches, so watching obviously what the BARDA did for the US, but also what the EU is doing with the Africa CDC, et cetera, that the autonomy that is wanted and needed is key to listen to. And so can we set more regional specific goals around vaccine access and how procurement is done and where production is done? And then pooling mechanisms can be there to buttress that. The end-to-end approach, we're not going to be able to do all of the steps in parallel at the same speed when we don't have a pandemic, but surely there are lessons learned that we could do sequential processes less and start doing more in parallel in a way that doesn't compromise on quality, and then also contribute to the shared regulatory pathways. And lastly, a global equity compact. So obviously, as just mentioned, with the actual delivery of vaccines, a global equity compact could have potentially mitigated such an uneven delivery, and at least we should get people protected from death and severe disease. But even if we look at what's happened currently with HPV, so in low-income countries have the highest burden of disease of cervical cancer. They have weak screening capacity, yet 90% of the doses go to high-income countries, and so it's one that's not only needed for for pandemic, it's needed also for routine vaccines as well. So we can make sure that that health equity goals are driving the allocations. There's still many unknowns. So while we try to shift our paradigm and our thinking, we still have to watch what happens over the coming months and the rest of this year before we can be fixed on any potential solutions. But we have a lot of opportunities to continue to learn and rethink, including understanding what is the longer term use case, what is the impact of country preferences, will there be an annual vaccination, and potentially with all this build out of production capacity, if we have like 15 billion doses of manufacturing capacity, can we pivot that and use it to vaccine where there's current shortfalls? And can we potentially use the nucleic acid platforms and others in a way that can drive earlier access for vaccines that affect children in lower resource countries as well? And with that, I will end. Thank you.
That's great. Thank you very much. Boy, lots to think about there. And I think, and I see already where the questions are coming in. So just before we get to those questions, we have one more panelist, and keeping on that global theme, we're now turning our attention, our focus to Africa's COVID-19 strategy. I think this is a key piece of the global pandemic puzzle that we're now all busy trying to solve. So here to speak on this is Dr. Nicaise Ndembi. Dr. Ndembi is a molecular biologist and, a molecular virologist and public health expert whose background includes a wealth of experience in clinical trials, HIV therapy, HIV drug resistance, and bioinformatics. He's a senior science advisor to the director of the Africa Centers for Disease Control and Prevention. He's also a research professor at Japan's Kanazawa University School of Medicine and an adjunct associate professor at the University of Maryland in Baltimore. Dr. Ndembi, thank you for being with us today.
Okay, so let me just probably provide some update on the Africa CDC's COVID-19 vaccine strategy. So the vaccine development strategy has three key pillars around access to clinical trial development. Means we've established a consortium for COVID-19 vaccine clinical trials. And the aim of that consortium is to ensure that Africa participates in COVID-19 vaccine clinical trials and also test safety and efficacy of some of these vaccines. The second pillar is around access, financing, and procurement, and on the need vaccine manufacturing with the aim actually to scale up African vaccine manufacturing capacity to produce COVID-19 vaccines in the long term. And the third pillar is around regulatory delivery and uptake. I think Eddie just did mention our joint studies with the London School on our team. So under the second pillar, we actually organizing under the manufacturing capacity a summit on the 12th and 13th to address really the need in terms of manufacturing capacity for health security. It's quite clear there's a slow rollout in Africa of COVID-19 vaccines, but I think it's quite important that we provide this update. I think again, I would really appreciate that. Yeah, you move to the next slide, please. If you can move to the next slide.
There we go.
Okay, great. So these are the three pillars for the Africa CDC vaccine strategy I did mention earlier. We first established what I've called a consortium for COVID-19 vaccine clinical trial. The aim of that pillar was to ensure that Africa actually contribute to vaccine clinical trials so as to actually minimize also vaccine hesitancy. That was the key point there. And then you can see several African countries have contributed to some of this vaccine clinical trial, the J&J vaccine clinical trial, the AstraZeneca vaccine clinical trial in South Africa, and some that are ongoing currently, the Sanofi Pasteur's in several countries. So the second pillar, we've acknowledged that there's a gap in terms of vaccine manufacture on the continent. given the current situations. We've seen that. And probably actually what we call the new public health order. I mean, the aim there is to be able to strengthen vaccine manufacturing capacity, diagnostic and therapeutics on the continent. So then the first, one of the first component there on the access is ensuring that we have enough resources on the continent to have access to the COVID-19 vaccine supplies. So I'm going to take you through that. We've been able to mobilize about $2 billion and also secured over 400 million doses for the continent. So on the third pillar is around regulatory, being able to establish a framework or regulatory pathway, and then also have a delivery alliance, ensuring that this is being covered for at least the 1.5 billion inhabitants we have on the continent. The uptake, Professor Heidi Larson did mention our study that we've conducted in collaboration with the London School. Yeah, the next slide, this bit to really address the fundamental issue around vaccine manufacturing. This has been called by the head of state to ensure that we have convened a meeting, a continental meeting, continental consultation to at least address the gaps and unlock some of these challenges on vaccine manufacturing. You're all invited. The summit is on the 12th and 13th of April. In the next slide, you can see there that we still have a slow rollout in Africa. We really aim to the COVAX facility that will complement our effort, and the specific instrument from the African Union, the African Vaccine Acquisition Task Team that we've established, and then also through bilateral. I can give you some figures. About 28 countries so far have received COVAX doses, about 16 million doses. And then you can be, I can tell you that about 18 countries have received over 10 million doses through bilateral. You can see that is a substantial effort through bilateral, having the Sinovac, Sinopharm, and the Russia's Sputnik vaccines on the continent. That shows you a level of commitment for member states to have access to those supplies. So what is our goal at Africa CDC? I think the target from the COVAX facility is to actually vaccinate about 20% of the African population. What we aim here at Africa CDC is at least 60%. And we've been really advocating for that. If you look at the target from China, about 70 to 80% by mid-2022, and the US about 80%, and then 80% from Italy. We have actually set our target a little bit higher to ensure that we mitigate and also limit transmissions of the virus on the continent. Yeah, so again, we're thinking really out of the box here. And vaccines, it's one component. Vaccinations is another bit that we're working currently with the EU and other partners to ensure that we roll out vaccines efficiently on the continent. We have the concept of vaccination centers. Currently, you can really, if you're familiar with our expanded immunization program, it's an overstretched system already, and we didn't want to go in there and use those facilities to roll out COVID-19 vaccines. What we're suggesting to build a completely separate those mega vaccination centers in cities, and that we're planning at least to use those ones to roll out COVID-19 vaccines. Let's say if you're in Ethiopia, in Addis Ababa, we could set up about 20 mega vaccination centers to be able to vaccinate about 2,000 individuals at least per week. That's the minimum target that we've set. And with the 60%, the target is about is to vaccinate about 720 million people by the end of 2022. The Africa CDC developed a dashboard. You can see that dashboard that provides the current status of the vaccines that have been deployed, second, the vaccine that have been administered, and the types of vaccines that have been actually administered on the continent. So in terms of vaccines access, 70 million doses from AstraZeneca vaccines have been so far delivered on the continent, and with Pfizer vaccine about 300,000 doses. If you look at the lower scales, you will actually see that some of these vaccines from the bilateral, both the Sinovac, Sinopharm, and then the Sputnik vaccines are also part of the pool of vaccines that's so far available on the continent. So there's a gap here. The gap is by June 2021, at least to be able to cover the need, the extra 45 million doses that will be required to achieve the 60% target set for 2022. And I did mention already this initiative, the Africa Vaccine Acquisition Tax Team. We've secured about 3 million doses from the J&J and the single dose vaccines, and also in negotiations with other vaccine manufacturers, including Pfizer. So where are we so far in terms of acquisitions? You can see on this map that about 26 countries have acquired at least vaccine doses that will cover at least 30% so far of their populations. If you can see that from that slide, we still have countries that have not secured or acquired vaccines required either through the COVAX facility, the AVAT through our medical supply platform, or through bilateral. So there's still a gap in terms of access, equity, and timely allocations of COVID-19 vaccines on the continent. So now in terms of where we are with our target, 60%, we have 17 countries within 30 to 60% in terms of acquisitions that are actually being able to meet our target at least by 2022 with through the different mechanisms I did mention, like South Africa. They are close to the 60% target in terms of vaccine acquisition to cover our target of 60%. And then the good news here, about 8 countries have at least acquired more than 60% the doses required at least to inoculate 60% of their populations at this stage. This is really leave you here with the type of vaccine acquired by member state. And the different by countries. We still have a white spot over there across some of the countries. Those are the countries that I mentioned that have not yet acquired enough doses to be able to, or vaccines to be able to achieve the 60% target that have been set by the Africa CDC. Yeah, so these are the critical priorities that we are actually, from the Africa CDC perspective, we are aiming to achieve. Being able to close the gap that I did mention, that you've seen, those countries that have not been able to have access to the COVID-19 vaccine supplies, being able to deploy those vaccines efficiently through different mechanisms, including the mass vaccination with the mega vaccination centers, being able also to provide some technical support and capacity building to member states to be able to roll out these vaccines on the continent. Thanks, and then again, apologize for the glitch over here. Thank you. Over to you, Chair.
Got it. Thank you so much, Dr. Ndembi. And boy, those are really, really telling slides and graphics. We really appreciate that. I think it's pretty clear there's a lot of work to do. So let's see. I'm going to go to Dr. Rappuoli first. We've got a question for you on, actually, to just step to the side from the vaccine question for a minute, a question about the cost and ease of distribution of monoclonal antibodies as a treatment option for COVID. Do you have any thoughts on monoclonal antibodies? This has been a pandemic where the vaccines have been out in front and the treatments and therapies not so much.
Yeah, well, I have to say that human monoclonal antibodies are not new. They've been used so far for, there are approximately 100 products already developed and approved by the FDA, but they're mostly for cancer, for basically inflammation, and for autoimmunity. And they're usually very expensive because they require a lot of material, and so they've not been used a lot for infectious diseases. Now, what has happened is that technologies moved a lot also for monoclonal antibodies. And today we can make monoclonal antibodies which are kind of 1,000 times better and more potent than the ones that used to be made like 10, 15 years ago. The consequence is that we can use less material, less costly, and basically we can get to reasonable prices. They will never be as cheap as vaccines, but they can be in the high range of the cost of vaccines, I would say. So especially our antibody was developed having in mind access possibly globally, possibly low-income countries as well. And therefore, we look for extremely potent monoclonal antibodies. The cost of goods will be low and will be affordable. So, briefly, the answer is usually monoclonal antibodies are expensive, but the ones we are trying to develop should be, able to provide access to most of the people worldwide.
Got it. And I have to ask you as well, you had near the end of your presentation, you talked about the fact that, 5 years ago, we're doing things now, or things are possible now that were almost unimaginable 5 years ago, especially the time frame in which these COVID vaccines were developed, and that 5 years from now, there could be other leaps that are hard for us to imagine. As difficult as that may be to imagine the future, we have a question. We're wondering about what you're dreaming about, where you see it going next, and there's been so much. Has COVID-19 been an accelerant for this technology, and where could it take us?
Actually, COVID-19 has accelerated the availability of technologies that were already in the science domain. So we were working on RNA vaccine in 2008. So it's not new, just been accelerated the development. I think, but it's indeed, now we have new tools like RNA vaccines that we didn't have a year ago. So I believe that, technology has really made possible many things. That just when I started making vaccines 40 years ago, a lot of vaccines that we have today were just scientifically impossible. And today we have them. So we conquer a lot of things, but there are still areas where the science is not ready. We still don't understand how to make them. And so if you ask me my dream, well, we still cannot make vaccines for cancer. We still cannot make a vaccine for HIV, struggling to make a vaccine for tuberculosis. Malaria can be improved a lot. Chronic diseases. I think there are a lot of areas where vaccination is going to merge with immunotherapy in the future, and we're going to try to solve more and more vaccines, using our immune system instead of trying to use drugs and other things. So that's, I think, where the science is going, and it's going to be fascinating, I believe.
Yes, it sounds like an adventure ahead. Now, meanwhile, I've also got a question for Dr. Larson on the hesitancy front, and really, this is more, I guess, sort of at the far end of resistance to vaccines. Dr. Larson, based on your research, what are the best strategies for addressing the spread of conspiracy theories about vaccines online? This is potentially, I guess, a potent source of resistance to vaccines.
Conspiracy is one of the underlying issues, and it feeds into a lot of underlying beliefs and already. And I think the best strategy for against conspiracy is to build resilience and confidence around it, because for those who are losing confidence, they're much more likely to believe in a conspiracy story that answers their questions, that makes sense of this incredibly complex environment now. So the more we can be out there with compelling stories that are keeping people on board with, and build our own kind of trajectory of why these vaccines are important. And this has been very much, a rollout of vaccines by press announcements, and it's really been difficult from an engagement point of view to keep people confident, and it's been a ripe environment for conspiracy. But we can do that, and we do have examples of interventions. There's a fantastic initiative, and I know there was a question about with healthcare professionals. I've co-created with some collaborators an initiative called Team Halo, T-E-A-M, Halo, H-A-L-O. And it's a lot of young scientists and young healthcare professionals who've got onto TikTok and are there answering questions. And I think getting those questions, catching them early before people go down the rabbit hole to look for consent. And they're not necessarily looking for conspiracy. They're looking for answers to some of their very genuine questions. We need to be there.
Got it. I also want to address a question to Shanelle about local vaccine production, and to what extent can that help with this issue of vaccine nationalism? Is it better, or are there strategies that involve kind of distributed production?
Well, I think it for sure would help. I think one of the challenges is the economies of vaccine production is that it would be hard for a country on its own to have its own vaccine manufacturing. So maybe it's better to think of it regionally or on continent. But definitely, if there's more autonomy and more empowerment over who controls those vaccines, it would help. And we can see, well, for decades, actually, there's been a really loud cry for there to be more on-continent production of vaccines in Africa, even more so in Latin America. And I mean, maybe this is a turning point for that. We could see that there is increase in Latin America. There's a lot in Asia, but Africa still is behind. It has just two vaccine manufacturers there, and one longstanding producing yellow fever. So yes, it would help with the kind of vaccine wars, so to speak, if there were continental manufacturing. And maybe another question is does it help with confidence if the vaccines are produced regionally? And I don't know if there's a connection between India having high confidence and being probably the world's largest vaccine manufacturing country in terms of doses in the world. It's a part of who they are. So yes.
Got it. I also want to ask you about COVAX and its ability to access excess vaccines from countries that will have more than they need. At some point, that will be Canada, presumably, because of all the contracts that Canada has, although we're far short of the doses we need at this point. But how easily can COVID access those excess doses?
It's one of the key roles that COVAX can play. So Canada is a participating country, you can say, of COVAX for exactly that reason. So is the EU. So are many countries. So it will perform that facilitation role to help those excess doses get delivered to countries that need them.
Got it. I want to also now turn to the rest of the panel, and perhaps we can bring in Dr. Ndembi as well, who's with us, which is, I'd like to ask each of you where you see us being a year from now, or perhaps 2 years from now. There are many different factors at play. There's the question of whether we'll need to have boosters for immunization, how frequently we'll need those shots, and so on. We're still in the first wave of the rollout, I guess is the right way of describing it. How is this going to look as we go further down? And perhaps we'll start with Dr. Rappuoli, but I'd love to hear from everyone.
Well, I guess this pandemic and this virus have been full of surprises. Initially, we basically underestimated that we'll be able to escape from China and conquer the world. Then we thought it would not change, and instead now we have a lot of variants. And so basically it's very difficult to predict the future. But I believe that the tools that we have, especially second generation tools, second generation vaccines covering also the variants, I think are going to take care of the circulation of the virus. But obviously we need to vaccinate the people. So you need at least 70% of the population to be covered in order to start to get herd immunity. So it will take a few years to deploy these things. And I believe that unless the virus surprises us again, I believe we'll need a boost also for the people that get primary vaccination. But with that, if we boost with second generation vaccines, I believe we should be able to control this virus in the next few years.
Dr. Larson, I'm sure hesitancy plays into how this is going to work, how well it works or doesn't. What's your thinking on the next little while?
Well, I think we're going into a different phase because we have multiple vaccines coming down the pipeline. I know that's definitely changed some of the sentiments in Africa. There's been quite a bit of anxiety around the AstraZeneca news, given that's the primary vaccine there. But yesterday's announcement about the new agreement about Johnson & Johnson has given, when people have a choice, it makes a big difference. And I think that that's going to change. And we are, and there is what they call social proof. Tens of millions of people have taken vaccines. And I think in terms of the issues around the AstraZeneca vaccine, we're very lucky this didn't come up 2 months ago when there were not so many people vaccinated. But we have for us the fact that just in Europe alone, 20 million people have been vaccinated with it. So when you have those numbers, it helps confidence. But I do think we're going to go into another phase. We have a lot of work to do with building confidence with healthcare professionals, and particularly if they're managing different vaccines with different requirements. We need to really accelerate on that. But I think we're going to go into we'll get there. We just need to be a bit quicker in getting prepared for it.
Got it. Dr. Ndembi, if you can hear me, I'm wondering if you can add to your perspective on what the unique challenges may be, for an African-centered approach to vaccination. As Dr. Larson mentioned, that it's been complicated with the issues that the AstraZeneca vaccine have faced. But what are the challenges in Africa to the rollout?
Yeah, I think I've sent a couple of slides to Kelty if she can put it up, because I've tried to summarize where we are and the challenges that we're facing currently. If she can put it up, they'll provide a perspective from the Africa Center for Disease Control, please, if you allow, Chair.
I'm sorry, she hasn't received those slides, so something didn't come through. But maybe you could just walk through them with us. Oh, she's just received them. Stand by. I'll tell you what. I will let Kelty get to those slides, and in the meantime, just to keep on that theme of the next year or two, Shanelle, I wanted to ask you what concerns you have about a loss of focus. When the first countries that are perhaps the wealthier countries who are fortunate enough to vaccinate their population soonest, what may happen with the rest of the world as they set about trying to move forward with their economies and so on, and how do we keep the eye on the ball globally?
Yeah, I think it's going to be important to go back to goal setting. I think the statement of no one is safe until everyone is safe really is true in terms of how the virus can continue to transmit, and if there's variants and whatnot. I think as has been said, super hopeful that we will be vaccinated by the end of this year. The world will be vaccinated, and as a result have herd immunity of a second generation vaccine that has been made available to all. And then we can get our focus back on issues of malaria, of access to HPV, of diseases that right now in some countries health services have reduced. And so there's a lot of concern about upticks in those diseases that otherwise are vaccine preventable or have a vaccine just on the horizon that could be rolled out. So we want to get through this to keep safe and get our economies back going, but also so that we can get back to focusing on really some of the larger killers of children in the world.
Of course, we're running a bit over time now, so we'll have to set questions short, but I appreciate those who were able to respond to the questions we had. I know there'll be many more, but of course, I don't think we'll be finished talking about these topics for any time soon. So with that, thank you. I also now want to turn it back to Dr. Rossent, and we'll wrap up our presentation and our panel today.
So yes, thank you very much, Ivan, and thank you again, all of our speakers, for a very fascinating tour around vaccines, vaccine rollouts, and vaccine confidence. I think we are looking to a more positive future, with obviously challenges along the way, and hopefully the challenges will be met by many of the people around the world. I'd like to acknowledge again that this is a great opportunity to bring Gairdner's mission to Canada and to the world. And I would encourage all of you, if you're interested in what we're doing through these kind of events, to go look at our website, www.gairdner.org. And in particular, look out for the announcement of our 2021 Canada Gairdner Award laureates, which will be next week on April the 7th. So please join us to find out which exciting scientists are joining the Gairdner family, along with the great people like Rino Rappuoli that we heard from today. So thank you, everybody, and we look forward to future events.